Good afternoon, everyone. Welcome. I am Alice Leiter. I am delighted this afternoon to be moderating our panel on addressing inequities in health data use, and thrilled to be joined by our four illustrious panelists. We have Adam Mariano, who's the Vice President for Health Innovation at High Point Solutions, which is an IQVIA company. Carlos Gutierrez, the Deputy Director and General Counsel of the LGBT Technology Partnership and Institute. Dr. Kevin Larson, the Senior Vice President of Clinical Innovation and Translation at Optum Labs. And last but not least, Laura Hoffman, the Assistant Director of Federal Affairs at the American Medical Association. Historic communities have been a victim of some of health data privacy. Extreme examples being, of course, the disproportionate populations persist today with harms both tangible and intangible. Broadly, these harms lead to a general erosion of trust in both healthcare and digital health technology. Today, we will be discussing the inequities that exist with respect to the collection and use of health data, and how, although certain data privacy provisions are relevant for all users, different communities confront unique and often discriminatory practices, including those related to algorithm bias. We will also discuss what we can do to shore up both consumer protections and trust in the absence of comprehensive federal data privacy legislation, and how we can improve the design and use of valuable technology tools to reduce these disparities. I am going to turn things over to our panelists for some remarks, and I will start with Carlos.
Hello, everyone. Thank you, Alice, for holding this incredibly useful panel, and thank you to all the panelists. I'm really excited about joining this conversation. My name is Carlos Gutierrez, and I am the Deputy Director and General Counsel for the LGBT Technology Partnership and Institute. And we are a nonprofit that focuses on the intersection between technology and marginalized communities such as the LGBT community. And one of the questions that we often get as a first question is, why is there a difference between technology for LGBT individuals and other individuals, and especially in healthcare? And I think there's a lot of reasons why data protection and privacy can be different for marginalized communities like the LGBT community. So a lot of the work that we do is highlighting kind of the differences of the importance of protecting a lot of the data for marginalized communities that may have been discriminated against in the past. So one of the things that we talk a lot about is kind of telehealth and the importance of digital technology for our community. As a community, it is well researched and known that LGBTQ plus individuals have a more of a hesitancy going to seek medical care. And there's a number of reasons for this. One of the main reasons is that LGBTQ individuals have often faced discrimination in their lives in terms of getting health care. We're one of the few minorities that actually can be discriminated against at home. And therefore, in smaller communities, a lot of LGBTQ individuals who may not be out will be hesitant to go to see their doctors or talk to their families about health issues that may come up, especially if it's related to sexual health. So a lot of concern that we have, and a lot of the potential for telehealth for LGBTQ plus individuals, is helping individuals in smaller rural communities that may have one doctor that goes to your church, that treats your parents, your cousins, and that you may not feel comfortable talking to if you're not out, or even if you're out, you may not feel comfortable talking to about sexual health. So telehealth can help rural individuals to reach out to communities and to doctors that can be much more understanding of their needs. Another way to do this is, LGBTQ plus individuals are known to delay going to the doctor because they're afraid of being discriminated against or for fear of not being treated equitably. So telehealth and digital technologies like this allow individuals to find affirming doctors and affirming care. This is especially true for transgender individuals. And for them, it's really important because the expertise that they need may not be in their community and may frankly not be anywhere for hundreds of miles around them. So the ability to do telehealth gives them a chance to work with individuals that are going to not discriminate and know their issues as well. Another big area where LGBT people suffer in a big way is kind of in the kind of peer-to-peer counseling and mental health services. There's a lot of stigma, obviously, with being LGBTQ, especially in smaller communities, in religious communities, in communities of color, and peer health and the ability to use telehealth to talk to counselors or to therapists or to other individuals that are going through the same experience as you are is one of the key uses of telehealth for individuals. And the lastly, and as important is, as the LGBTQ population gets younger, they are used to using their phones for all of this. The Trevor Project has launched a text system, and the Trevor Project is a national LGBTQ suicide hotline. And now they have text services, and we have to keep up with the technology if we're going to reach individuals that work with us. But having all of this also brings a lot of dangers for our community as well, in terms of being outed, in terms of having their health data exposed, in terms of facing discrimination based on their sexual orientation or health status. And we've seen this in the past with HIV laws. We have seen some of this with contact tracing laws, where neutral laws can be applied in a non-neutral way to discriminate against marginalized communities. And so these are some of the ways. And so the data protection of health data, which is crucial to everyone, can be especially crucial for marginalized communities, where the data can be misused or it can be leaked in a way that not only reveals your health status, but may inadvertently reveal your sexual orientation or gender identity, and place you in danger. So there's a lot that we can get into on this, but that's kind of like the main thrust of where I'm coming in from this conversation.
Thank you so much, Carlos. Yes, it's unfair to have 50 minutes for a panel like this, because each of these individual topics and each of your remarks, I know in the discussion could go on for hours, but that is a very helpful overview, and we're so happy to have you with us. If I could go next to Adam, please.
Hi, folks. I'm Adam Mariano. I run product and strategy for a division of IQVIA. IQVIA is for those of you who don't know, is a large clinical research organization. We're the largest outsourced clinical research organization globally. We're also a very large provider of syndicated health data. So we're one of those organizations that aggregates and integrates data and has a very clear view of how data is being used holistically, globally. Within the practice that I work in, which is the integrated health practice, we are the largest provider of patient registries from a global footprint. So we support patient advocacy groups, medical specialty societies. We also work with life science companies in late phase and post-market studies, where we're trying to understand the actual impact of life science products on patients in their daily lives. On the advocacy side, we work with a lot of brand name advocacy groups that you would know, helping them support patient journeys across their whole healthcare ecosystem. So as a patient comes in and gets diagnosed with a disease, or one of their children or a loved one needs support within that realm, we actually help all those institutions build, run, design, and ultimately support their registry assets for their patient ecosystems. To that end, one of the critical things I can share about me from a background perspective, I actually came out of the nursing space. I'm a clinician. I've spent the last 20 plus years in healthcare IT, focused on data access, integration, and interoperability. I'm also a civil rights attorney. That's my side gig, if you will. And I come out of the public health space. So in the role I sit in, we advise organizations about a couple of things. One, how to integrate all this data for the benefit of patients, and moving from what was provider-driven to what we heard of as patient-centric healthcare for the last 5 to 7 years to now patient-driven care, where we're putting patients at the center of a learning health model and asking them to provide input around the real critical things that are either preventing them from receiving care, barriers to engaging in research and other facets of healthcare, or critical needs that they're missing from a community perspective. So we spend a lot of time advising those organizations about not only how to do this effectively, but places where hidden exclusions and hidden barriers to patients arise all the time. In the commercial clinical trial space, I think the pharmaceutical industry has always struggled to get beyond prime and partner sites, the big sites that large institutions go back to over and over again to do clinical research. That often excludes community organizations, that excludes local health institutions, and it excludes a lot of other places where people get healthcare that aren't in the traditional research health market, which means that not only are communities at risk, and often communities of color or underserved communities not being represented in these spaces, but their data is being disconnected from their own personal experiences in those clinical trials. So one of the places we spend a lot of time talking is how do you lower barriers to inclusion, but also think about the technological hurdles that might keep patients in underserved communities from participating. A really silly but very tangible example is there's a lot of interest in digitizing engagement in clinical trials, in registries, and in patient engagement, and you'll see that folks will decide that they're going to run a trial completely on Apple devices, for argument's sake. Apple is no discrimination to Apple, but Apple is a relatively expensive device. The distribution in the US is about 50%, so half the market is excluded the minute you choose that device. It's also on a lot of underserved communities that aren't always on open data plans, are in prepaid markets, and other phone vendors. They're not Apple devices, they're Android devices. And so simply by making a technology choice, you can not only exclude patients from being part of a process, but also restrict data access to their own data because they don't have digital access to those data assets. So spend time advising in those spaces. We spend time talking about how to design registries and onboarding processes to make them more friendly to folks, to think multilingual by default, which is one of the other critical things, especially in the US, because we are Anglo-centric. English tends to be the lingua franca of conversation, and the reality is silly things like informed consent being not transliterated, but well translated like we would do for localization in a third-party country. Thinking about data portability. So how do you put assets like these back in patient control? As ONC and Cures has started to push not only data into patients' hands from payers and providers, but has encouraged pharmaceutical companies through FDA guidance to start to think about real-world data collection as part of their trials engagement. We're going to see a real tidal wave of requests of data from patients to share as part of trials, and making sure that informed consent is understood, is in plain language to patients. It's not legalese. That we're always repeatedly asking for patients for permission. So if you're going to collect data 5 times during a clinical trial, that you ask them to reprovision that data each time, so it's clear what's happening. And thinking about places where engagement with patients can be easily overlooked simply because they've been outside of the engagement space before. So I won't belabor it there, but I think there's a critical opportunity as we start to tech enable these resources that were always manual data collection, where we interviewed patients and wrote down their data, where providers entered data into electronic case review forms, or where we collected what were manual insights to now be automated. We want to make sure that 2 things happen. 1, we don't exclude folks who don't necessarily have access either because of the tech or the information divide. And 2, we're thinking wholeheartedly about how we interpret things for folks who are naive to the research space and bring them in with a real welcome. And I think this applies essentially to all populations, but it's a really great place for us to start. It's where we spend a lot of our time as an organization.
Thank you, Adam, and thank you for the work you're doing, I should say, to Carlos as well. Kevin, let's go to you next, please.
Sure, Kevin Larson, happy to be here. I am a physician and a medical informaticist and work at Optum. I've been at Optum Labs, the health services research component of Optum, for about 1.5 years, and recently moved over to a new part of the organization that focuses on point of care enablement. How do we get good information easily in the hands of clinicians and patients as they're doing their work. Clinical decision support for those people that are kind of more in the health IT space. Before I was here, I actually spent a number of years at Health and Human Services, notably at ONC and at CMS, Office of National Coordinator for Health IT. I led a lot of the work there on standardizing the demographic data, including race, ethnicity, preferred language, as well as sexual orientation and gender identity, establishing some of those standards for use across healthcare data interoperability in the country. And before that, I was the Chief Medical Information Officer of Hennepin County Medical Center in Minneapolis, and also ran a health services research group focused on health equity. And a lot of my work and time at Hennepin County has really informed how I think about the rest of this work around health equity. So for those of you not as familiar with Minneapolis, Hennepin County Medical Center is the urban safety net teaching hospital and the referral hospital in Minneapolis. Minnesota has some of the best health outcomes in the US. However, we also have some of the widest health disparities. Part of the knowledge we learned from Minnesota is that if you have a much smaller minority population, less than 10% population, if you average out outcomes, the majority looks good. You actually have to dig in and look at the minority populations and understand that those minority populations are not doing as well, and you have to have good data to be able to do that and be able to see what the difference is. So the example that the Minnesota Health Department used a lot was that Minnesota has the lowest teen pregnancy rate in the US, but we have a zip code in Minnesota with the highest teen pregnancy rate in the US, and that zip code is in a primarily African-American part of Minneapolis. So at Hennepin County, because we served a very diverse population, a diverse ethnically, diverse racially, diverse with language, largest LGBTQ population in the state, we really thought very carefully about how we collected data, how we use that data, but I think more importantly, how did we partner with communities and how did we partner with people to really have open up the locus of control to the community and to these subpopulations to help actually bring their expertise in and ask their questions and drive that work. That was really when we had some great ahas and outcomes, when it wasn't just the academics asking the questions, when it was the community asking the questions, the community saying, hey, what about us? What about this? Also worked a lot to focus on the strengths-based approach, not just to focus on where are things, where are the deficiencies, where there are inequalities, actually where are their strengths and how do we learn from those strengths and bring that into our research and bring that into our work. Happy to be here.
Thank you so much, Kevin. And again, last but very, very much not least, Laura.
Hi, everybody. Thank you so much for having me here today. I'm really pleased to speak with all these panelists and with you on this important topic. And I will say, the AMA is kind of all in on digital health equity. We've been working on many, many things related to this. So I thought I could give you a brief overview of some of the things that we've been putting together, many of which are coming out probably by the end of the year. I'll start with a brief background just on my work history. I'm an attorney by training. I joke I'm a recovering attorney now. So I work with I was previously in a law firm that focused largely on community health centers and community behavioral health centers and ensuring that they had support for their grant needs. But during that time, I also started developing kind of an expertise in privacy. It was right around when the HIPAA omnibus rule came out, and as kind of low person on the totem pole, I was tasked with understanding that rule. But fortunately, I think it was actually a beautiful twist of fate, because I really think privacy is essentially a human right. It's a civil right, and I think that the more we start thinking about data and privacy rights in that way, the more robust the conversation comes and the more good we do in serving people who, to Adam's point, we need to use data, and Kevin need to use data to help improve care of populations, but also to the points that Carlos was making, we need to ensure that there are robust protections to help ensure that data sharing doesn't create or exacerbate inequities that already exist in the system. So I think this conversation is really important, and I'm really thrilled to see that privacy is getting more attention in the healthcare space. Let's see, I guess I'll start by saying that it was about 2 years ago almost, early 2020, the AMA released a set of privacy principles. And these principles were based largely on longstanding policy of the AMA, which is developed by medical and state specialties across the country. And really it was following the release of the information blocking rules, which, and this kind of touches on a point that came in from an audience participant about the impact of the information blocking rules on data and privacy. We really started doing a lot of thinking that while these information blocking rules will go a long way to helping patients access their own information, it's something we're very supportive of. At the same time, we're really shifting the paradigm to pushing a lot more health information out from kind of the covered entity HIPAA space into the non-protected data space. So what does that mean for people as more and more information is out there with fewer protections? And in fact, there's a lot of loose regulation around who all can request information on behalf of the patient by virtue of these rules. So we wanted to make sure that we were kind of putting a marker in the sand, both for the information blocking regulations, but also for federal privacy legislation, which I know we'll talk about in a little bit, to say that, look, confidentiality of healthcare information and increasingly most kinds of information, whether it's traditionally thought of as healthcare data or not, or sensitive data or not, you can make a lot of inferences about an individual's health through their data and through the patterns that their data kind of expose. So we created this document. It's broken down into several sections. Individual rights, entity responsibility, equity, and then kind of the more legalistic, like what we want to see in terms of enforcement and kind of what federal regulation would look like around privacy. And the equity and individual rights pieces, I think, are really what I'm most proud of with this document. We're saying that people do have a right to control the data and the inferences made about them through that data, whether it's by using tools, digital tools, whether it's by not using digital tools, and essentially, trying to say that it's gone on for far too long where large companies have access to data and can use that data for harmful purposes. The FTC put out a report several years ago, about big data and the power to help and the power to harm. And lots and lots of conversation is happening around the power of big data to help. And I think we need to also escalate a simultaneous discussion around the guardrails that need to be put in place to ensure that that data does not harm individuals as well. Just plainly speaking, big data can provide opportunities for inclusion for certain populations and also for exclusion. The fact that I'm a female could be used to target information to me or to exclude me from opportunities for various things. Same thing goes when you start to talk about people who are part of historically marginalized communities. So that's the privacy principles. Now I'll wrap this up. The other things that we have coming out by the end of the year are kind of moving towards the innovation space and trying to expand the conversation beyond just how data is used, but also thinking about how technology is designed. What is privacy by design? What is equitable innovation? How good are privacy tools if to Kevin's point, or I'm sorry, I forget who raised it, but if the information is only presented, maybe it was Adam, if information is only presented in English, or if you're trying to reach individuals who are vision impaired and they can't see the tools because you haven't kind of thought about audio controls, right? So we're going to be releasing a paper that essentially takes our privacy principles and speaks to a developer audience and kind of provide some guidance on how to actually operationalize the privacy principles in a developer specific way, using kind of more developer specific language around shoulds and shalls and the kinds of controls that are and functionalities that are needed in technology. Last thing I'll mention that also will be forthcoming soon. The AMA has a Center for Health Equity, and we released a strategic plan earlier this year. And one of the key components of that plan has to do with equity and innovation. So to help support that work, we're developing a set of equity and innovation principles for developers, for venture capitalists to think about, what kinds of developers and innovators are receiving funding from the healthcare industry. There's so much money in this space, right? So why aren't we funneling more of that money into the developers and the minds who have diversified life experience and can bring different ideas to the table? So the AMA put together an external advisory group. Actually, Abner from the privacy or from the previous panel is part of that group. And so we're releasing these principles hopefully by the end of the year, along with a solution assessment guide that we hope will be helpful for developers and for venture capitalists and innovators to really think about how their solutions meet specific equity goals. So I'll stop there and hopefully, keep an eye out for those resources and looking forward to the rest of the discussion. Thanks, Alice.
Thank you, Laura. And wow, if the four of you were in charge of the world, I think we'd be in better shape because this is some really good work that's all going on. Before I start a discussion or questions and answers from the audience, I wondered if any of you, the panelists, wanted to comment on anything that each other said. I think there's some clear lanes of the work you're doing, but also some overlap. So just to turn it back to the others, if there's anything you wanted to follow up on or mention from each other's work.
I would share a lot of the conversation that Laura's raising as desires in the space, I think speak to two things we're seeing very clearly. The Cures Act ONC rules and the patient access rules have led to an explosion of, I'll call them health wallet applications. Here's a way for you as a patient to carry around your health data on your phone. To Laura's point, that moves you from the HIPAA space because you're now into a non-covered entity. You have patient permission to pull that data and to host it. And so all of those controls that we spent so many years arguing about HIPAA, and everybody's gone through all the HIPAA trainings and all of the onboarding exercises, they no longer apply. And so now you're in a strict consumer space, and patients are unaware often of how their data will be leveraged. No one I'll say this in the blankest capitalist forms possible, no one's helping them monetize their data. And so instead of being very clear about the fact that, look, someone is monetizing your data, you should probably not let them. One. Two, if you're going to let them, you should be 100% aware of how that data is going to be used. Three, you don't have to monetize it to carry that data around. So Common Health, Common Pass is a nonprofit organization. They have a framework. They'll share that. They're being adopted as one of the global standards. Apple Health Kit, is the Apple version of that allows you to do this yourself without necessarily sharing data. All of those institutions will still use your data in some way. They're going to aggregate patients by demographics, by disease type and other things. But some awareness and sharing with patients about, hey, if you put data in these spaces, yes, you can be empowered, but you should be aware that there is, people have to make money in order to share that service with you. So in some way, shape, or form, they're either creating a marketing well, they're looking at targeting for life science companies, they're doing something that is driving that patient data into other people's hands. And so I think there's no clear standard for that awareness at all, and they're not being managed like consumer tools. So there's a there's a gray space for now till legislation catches up that we're going to have to deal with to keep patients safe.
This is Kevin. I fully agree. And spending my time at ONC, we heard from the industry, don't regulate us, but hey, we want you to regulate these other people. And we'll only do things if it's actually regulated. So part of the kind of flip side of this data sharing and equity coin is when the government does lean in and mandates it, then suddenly there are all sorts of pressures on organizations to collect this kind of sensitive demographic data, collect sexual orientation, gender identity. That's how we'll see the disparities. That's how we'll know that things exist. But it also means that it's going to happen and people are going to work to share it and people are going to work to use it, both for studying equity, but also to build products, to build personalized recommendations. And eyes wide open, I think, with all of us. And I love what Laura said about designing in privacy. As much as we can design in privacy to the system, and as much as we can give people tools that they can understand where their data is used and how it's used, we're going to be better off. But we see NCQA leaning in here. I was just looking this morning at the CMS Innovation Center's new strategic plan. Equity is a cornerstone of their new strategy. That's going to drive new kinds of data collection. That's going to drive interoperability of that kind of sensitive data, and then subsequently equity analysis downstream. So I think we're at an inflection point where we can help influence how this works and really lean in and say it should be done this way and not done that way.
Well,
Yeah, sorry.
I was going to say that's a masterful segue into what we want out of new comprehensive federal data privacy legislation. You know, I, like Laura, am a recovering lawyer, so I don't mean to pin too much on what a new law might do for us. But it is true that the sort of probably majority of health data out there now is not held within the traditional healthcare system and therefore not covered by HIPAA. Europe is ahead of us with their GDPR. Some of the states are ahead of the feds with respect to state privacy laws, notably California's Consumer Protection Act and more recently Virginia's. If we have to look for a silver lining of not having a federal law that shores up consumer privacy, maybe the benefit there is that given that where we are sort of nationally in this moment talking about equity more than perhaps we have in the past, we have an opportunity to build a law through our advocacy, through discussions like this, that is one that we would really like. So I wonder if you all have sort of Pollyanna visions for what that unicorn privacy law might do, that takes some of the important HIPAA protections and molds them and adapts them to this, what we call now the Wild West of consumer data protection. But how can we build in equity protections, access protections, consent provisions into a law that also allows companies to feel safe that they're being regulated, but also not hamper or dampen innovation? I recognize that none of you are legislators, but as we adapt these principles, what would be our best case scenario here?
I can start just based on kind of what's in the principles, and then please, my panelists, co-panelists, take it away. I think a lot of the foundation is built on really decades long kind of core tenets of privacy law, things like data minimization, things like transparency around who is getting your data for what purpose, what are they using it for, who are they sharing it with. We would like to see very granular controls given to consumers so that they're able to say, yes, I want my information shared for research or drug development, but not shared for marketing. We would like to see a private right of action. We would like to ensure that the federal law does not weaken stronger state laws. If the federal law wants to be stronger than every state law, great, but I don't know that I see that happening. In terms of the equity pieces that we threw in, I think it's incredibly important every time we talk about data sharing again, because there's so much emphasis on data sharing for the good purposes, and not to take away from that, but those conversations always have to be coupled with non-discrimination protections and guardrails around what's going to happen to people if that data is misused. I mean, HIPAA's been around for what, 25 years, and clearly breaches happen all the time. So it's going to happen. So what are the safeguards you're building in case information collected for contact tracing in public health is shared with, immigration enforcement agencies? What are the safeguards there? What are the safeguards to ensure that benefits will not be cut off to individuals who, maybe the government doesn't look favorably upon those populations? I mean, we just had some interesting civil rights changes in the last administration that are hopefully now working their way out, but you have to think about I at least have to think about the worst case scenario. Maybe I'm just an eternal pessimist, but there's a quote from Ruha Benjamin in Race Against Technology that it's the language of process or of progress is too easily weaponized against individuals who suffer the most under oppressive systems, no matter how sanitized. And so we always need to be thinking about those people who are oppressed, who are marginalized, and try to build in those protections from the start. And I would say this applies not only to traditional health data, but also we need to be thinking about social determinants of health data, social risks, and sharing that increasingly outside of the healthcare system with community-based organizations. We want that care coordination to happen, but we need to make sure that we're ready for it and thinking about it from the start and not bolting that stuff on at the end.
Yeah, I think Laura raises some really good points. I think one of the places where we're going to run into struggle is just practicality. And so I having come from the clinical space into IT space and had to take my very idealistic nursing hat, where I was very much trying to save people's lives, or at least so I thought every day, and then drifting into the IT space, which is very literal. Thinking about what standard data sets look like for sharing and establishing a standard like we do with FHIR. So, Laura, you touched on social determinants and, the standard set for social determinants that's trying to be derived and then being used for digital measures and other things brings to mind an idea that, well, if you had tiered data that you could derive from, say, the FHIR US CDI standard, and of that data set, if you wanted to share data for marketing purposes, there was a standard de-identification process, a standard non-discriminatory de-identification process that gets validated by a third party, and it has to go through that minimum stricture. Then what you've got is, okay, the patients can get a clean bill of rights, but then it's a standard process for deriving data from the source. So you remove a lot of the cloudiness that goes into, well, we're just going to share elements about X and Y and Z about you when that's not clearly defined. If we could clearly define that at the data element level, or data type or resource type, then what you've got is a clear map for organizations to put in standards-based sharing. The patient then has a very clear definition from every system is exactly the same. And then you end up with a national standard around what the data sharing bucket looks like, what that packet of data looks like. Then it's easier to start to drive standardization from a law perspective, and the crazy differences between what will be California law and, say, South Dakota law, which tends to be much less restrictive and is not as consumer protective, if you will, and the California versus GDPR concerns. You can map those down to data elements and start to think about those as standards. And as we start to produce more law, the law can be tied out to resource types as we go forward. So something that's, to me, it feels it's an engineering solution to a legal problem, but it feels like it's something that could be sustainable. And the other thing I'll point out, it's just something maybe to filter into this conversation, is everything we're talking about is digital access, which means the information divide doesn't solve that problem. And one of the things we haven't talked about as part of this is how do we easily make non-digital access to this data available to patients in a way that can be shared, whether that's shipping them a key fob that they can share with a provider, or it's back to horrible paper charts. There's something in between. I've got an expensive device with an unlimited data plan and paper that we probably have to start to think about as part of the solution as well.
So
And just
Adam,
quickly-
I love your thoughts about practicality. So again, thinking through my time as a CMIO of a health system, most of my patients, when we would survey them, expected their data was moving. when we would go do focus groups at the homeless shelter and say, well, what did you think about us sharing your mental health data? They said, you mean you're not? Like, I thought you guys were coordinating my care. And so there is a sort of consumer expectation, at least among care providers, that that data moves really smoothly and easily back and forth. And there are definitely reasons to have some limits of that, and a lot of patient ability to control what is shared. But from a practical standpoint, the volumes of data and the complexity of the data has made it challenging to maintain the metadata and the provenance about those individual choices that patients make, because they're very different person to person. It's not like there's one class of data, suddenly we're just not going to share lab results, or suddenly we're just not going to share mental health. It becomes a very nuanced. There's a question here, like, can I share my sexual orientation with some people and not with other people? Can I share my gender identity with some people and not with other people? I totally laud those goals, but that your gender is in so many forms, in so many places, and so much a part of this healthcare system, and it shows up on your claims form, and it shows up on your immunization card, and it shows up everywhere, that maintaining that metadata and those controls is really hard to do through all the places that that data passes through its life cycle. I'm not saying it's impossible. I'm just saying practically it's proven to be very, very difficult to do that down to that individual data element with the provenance of metadata that is implied in being able to pass that forward.
And then one quick thing, obviously as a marginalized community, we definitely support a very strong federal privacy law. Marginalized communities do not often do well in a lot of states when we do a state-by-state law thing. So we would like a strong floor. I think one of the big challenges we're going to have as we talk about this is definitional, like what is health data for purposes of federal legislation, because as we talk about all these apps and all these other kind of things that we're talking about, these are non-traditional. One of the things we run into when we talk about this is that people overestimate what HIPAA covers and they underestimate what health data is. So we can talk about geolocation, and if you go to the same HIV clinic every week, that should be health data. You can talk about your web history. If you're searching for certain medicines, if you're searching for some drugs, that should be considered health data. So I think definitionally, we have a big question in front of us is how do we tackle this in a way that's not, talking about covered entities, but more about the actual data itself? And how do we make sure that sensitive data like SOGI data and other data that can be reached across these apps is protected outside of covered entities?
I think that's an excellent point. And I know that the work that eHealth Initiative and the Center for Democracy and Technology have been doing on non-HIPAA covered data has really focused on a very broad definition of health data for exactly the reasons that you say, putting the onus on the companies to protect privacy rather than on consumers to have a full understanding of what their rights are, and putting it on a consumer to have to understand or wade through terms of service, and really focusing on the purpose for data use rather than necessarily the individual data elements. So hopefully some of the work that we all have been doing in concert is going to lead to those types of provisions or themes being part of a new federal law, or at least one can hope. We have a few minutes left, and I did want to address a couple of the questions that have come in from the Q&A box, although I, of course, have a long list of questions myself. Someone asked about recognizing patient comfort levels and being out with the doctors that they see as sympathetic, but then how might data exchange rules affect this? How might the status spread beyond what the patient explicitly puts out there? I guess that's a question too. Again, we want there to be care coordination, but I wonder how, as we promote care coordination, as we do in so many places, and as the HIPAA proposed rule, who knows what's going to happen with that, but really expanded the extent to which data can be shared for purposes of care coordination beyond some of the more traditional or explicit provider channels. Do any of you have thoughts on how we can protect privacy as we, at the same time, push for greater data exchange for both treatment and care coordination purposes?
So I will put in a plug for our work group. I put it in the chat as well. It's called pptpi, Protecting Privacy to Promote Interoperability. And basically it's a volunteer-driven multi-stakeholder group that is essentially working on the standards that Adam and Kevin were talking about. And we're very much trying to, the ultimate goal is to develop an IG, probably will be FHIR-based, an implementation guide. But really we're starting with 2 use cases. One is around reproductive health for adolescents, and one is around behavioral health for geriatric patients, and really breaking down kind of like each step that you all were talking about and how to, preserve that provenance, metadata, et cetera. So I'd encourage folks to check that out if they're interested in that work. It's I think, very exciting. And the other point I was just going to make about the information blocking rules, I think it's an excellent question. It gets a little bit to what I was alluding to earlier, where this gets a little bit in the weeds, but again, while I think it's so critical to encourage sharing between covered entities, community-based organizations, et cetera, as kind of the HIPAA proposed rule and information blocking is envisioning, there's also a real threat that, again, patients aren't going to know exactly where that information is being exchanged. Kevin, totally hear you and agree that there are plenty of patients, including some of, the unhoused population, where they want this all to be done behind the scenes and yes, share my information. But then there are also scenarios, Carlos, for example, in some of our comments, we included an example of, say an individual, maybe it's a gay man, needs food assistance from his community church. And the community church reaches out to that individual's clinician to say, hey, I need your nutritional needs. But because of a lack of technology, the doc can't send just the nutritional needs to the church and sends the entire record and then reveals that individual's sexual orientation. Now what happens? What are the repercussions there for that individual in his church community and his food needs, right? So I think, again, those are just kind of some of the things that we have been trying to think about and talk about with ONC and other regulators when it comes to the information blocking rules. I think there's a lot of promise, but there's also a lot of unanswered questions. How do the CBOs protect that information and keep it secure? What are their access role controls? So I'll stop now and see if others have thoughts.
No, you make a great.
I'll also mention.
Everybody's excited. Yeah, I was just going to say, there's a deep technological excitement, and I think having worked with an awful lot of CIOs and CMIOs and CTOs who are really excited about the fact that you now have a FHIR-based standard for leveraging this data and doing interoperable things. The problem is that it now V2 of US CDI exposes all the narratives. And the narratives are just littered with PHI and exactly the kind of thing that was talked about in the question, which is, you're probably not going to find that discussion with the physician or the nurse practitioner in the atomic data, but you're going to find it in the H&P narrative or a discharge note or something else that people often don't know how to exclude from the data set in transmission. That's just, speaks again to the reason about how we should scale this data and make sure that we're eliminating things that create risk. And we have the same problem in clinical research. There's a lot of data that you just cannot share downstream to sponsors because there's no way to effectively eliminate PHI from what is essentially a narrative. I'll stop there. I don't know, it needs a whole lot of elucidation. It's a clear problem.
Yeah, I was going to highlight there is another federal standard that it's worth people knowing about called the DS4P, or Data Segmentation for Privacy. It's a standard that was in many ways created by SAMHSA to help around a federal regulation called 42 CFR Part 2. And for those of you in the mental health and chemical health space, you're pretty aware of this, but that rule says that there are much tighter protections on sharing data from places that treat chemical addiction, chemical dependency. So especially think methadone clinics. They have very tight privacy controls, but they also know and they want to be part of an interoperability world. So this data segmentation for privacy standard was created and piloted through SAMHSA and some of the other organizations to be able to follow those federal regulations of assuring that kind of sequestration of key kinds of data, but also allowing other types of information actually to move back and forth. So it's worth looking
Kevin.
at.
We're actually just going to have to start. We're right at time, and our next panel starts at 1:10.
Yes, thank you, all of you, so much. Clearly, we need 6 hours for this conversation, so hopefully we can gather again. I'm so grateful. And please, all of you, stay tuned for our next panel, How Virtual Care is Expanding Access for Vulnerable Communities. Thank you all again.
Thank you all.